You're watching Joy News Prime, and joining us on phone now, or joining us on Zoom now to talk about what was shared at Tuesday's news conference is virologist with the KCCR, Dr. Michael Usu, who's also a lecturer at the KNUSU. Thank you very much, Dr. Michael Usu, for making time to speak with us. Now, my first question to you after the news conference on Tuesday is Ghana really at the peak of the infection curve, as suggested by the Director of Public Health?
Yeah, it's a bit difficult to tell now whether we are at the peak of the infection curve, and I'm being cautious making this statement because I'm aware that there are a group of modelers, mathematical modelers, who are trying to model the curve, the epidemic curve of the virus using real-time data, which is being collected from the Ghana Health Service. So I think that I will want to wait for the model that will come out from this data, especially because a lot of the samples we have collected, the data which have been shared, seem to have been from backlogs, and these are not real-time data. So using that to extrapolate the peak curve is a bit difficult. So once the Ghana Academy of Art and Sciences are doing this, I think we need to wait for them to come up with the model, and they can describe the epidemic curve and to tell us exactly where we are. And also, this epidemic curve will differ from region to region. It is possible Accra may hit its peak, but then Kumasi will begin to climb the curve. And from Kumasi, Eastern region may follow. So that is why you could have regional epidemics. You could declare epidemic centers from region to region and district to district. So I think I want to wait for the modelers to come out with their model. Then we can understand exactly what the real-time data is telling us.
All right, I don't know what figures the Director of Public Health is looking at or based on to suggest that we are at the peak, even though he goes to concede that it depends. The rest of it depends on the way Ghanaians observe the measures that have been put in place. But if you have a situation where we added 550 new cases just yesterday, and the KCCR2 also, Noguchi says it's cleared its backlog. KCCR says it has just about 2,000 tests to go through. Could it be, or are we looking at a situation where the cases or the reports that we're going to get will not compare with the 550 or the hundreds that we have recorded in the past?
It is possible. I mean, if you look across the globe, each of the countries have an Excel sheet. The Excel sheet has every day the number of new cases that is recorded. So you can easily download the Excel sheet and then take on from 12th of March, when we first detected our first cases, go through to date and see how many new cases we record each and every day. And the challenge has been that it's difficult to link the day on which the samples are reported to the day on which the samples were collected. So there seems to be a gap between these two dates, and therefore using the date on which the lab reports a sample to extrapolate is a bit difficult. You are likely to make some marginal errors. So I think that most of the data we have reported, I mean, from our end, because of the huge numbers of contact tracing samples, there seems to be a bit of a delay before that. So we could be making predictions, we could be 3 weeks behind. So now that we are almost about to clear all the backlogs, the data that will be coming afterwards are likely to reflect the key data which will come in real time and which will inform us as to what to do.
Does that suggest a deficiency in the way we went about collecting our samples? Because we should have been able to, as you're indicating, indicate the days on which the samples were collected and do the test accordingly.
I don't think it's a deficiency. I think that it's a learning curve, and all of us are part of it. I'm also a part of the process, and we have been working very hard to ensure that all of us put this data right and connect this properly for public health use. Because we were overwhelmed by this. It started on 1, 2, 3 cases whilst putting in the structures, the cases began to troop in their numbers and thousands. And all of a sudden, we were all caught up testing. And it's not just about testing, entering data, correcting case investigation forms, aligning them properly, reporting in real time. So I think the huge surge in cases and coupled with the way the cases came in is what perhaps unaware all of us were caught in. But the good thing is that these are files which are there. The data is available. We are going back to realign them, which would mean that we haven't lost anything. We can still correct it and be able to make our projections, which is what I think we must focus on. I don't think it's a deficit. I think that it's a pandemic of this nature. We've never experienced it before. This is the first time as a young man I'm seeing such pandemic, which means that a lot of the things that we are learning in subsequent years, we can be able to adopt more pragmatic measures to prevent a possible delay in things, and then put down the things structure so that we don't experience what we are experiencing.
All right, Dr. Michael Usu, my final question to you has to do with what you make of the strategy at this point. What should we be doing going forward?
Yes, so going forward, I think we need to understand what we have now. Look at Accra. Accra has over 2,000 cases. Kumasi has over 100 cases. Each region is following. So what is important is for us to begin to classify these regions into phases. And depending on which one you use, if you use the African CDC model or the proposal, Accra is likely to be in phase 4, which means there is a large pervasive local transmission of the virus. When you have a case like this, you need to prioritize your testing, which is very, very important. Over the time, we have done a lot of community contact tracing testing, looking out for active cases, and that is what has helped us to break transmission cycle of the virus. But where we have gotten now, where we have a lot of pervasive local transmission, it is good to begin to focus on the healthcare facilities where we channel all our resources into and to deliver real-time results to these people. The reason being that our mortality is a little below 1%, which is very good. How do we keep on with this? If we are able to go through the healthcare facilities and test everyone with disease, irrespective of whatever the person comes out with, if we are able to do this, then we can pick up those with severe disease in real time, manage them properly, and ensure that they don't develop into critical illness, and therefore they don't die. The next important thing is that if you have a region with local transmission, you want to focus on the healthcare workers. Because if the healthcare workers pick up 1 or 2 of the viruses, they can trigger what we call the nosocomial transmission of the virus in the healthcare setting. That is the #1 killer of a lot of people, in the midst of the developed world. So what you want to do is to ensure that all health workers, especially living in the Accra zones, are tested. These are syndromic testing, so that you can pick up those who are positive, quickly isolate them, and free the area of all these individuals so that you don't have a cycle where you could have transmission going on the healthcare setting, not by people who are coming in, by the workers who are working. So doctors, cleaners, everybody, lab scientists, pharmacists, everyone who works in the healthcare setting, including records, should be able to do this so that you'll be able to at least isolate them and then not have what you call a nosocomial transmission occurring. So you can keep your mortality still below 1%. That is very essential for us to do, especially in a place like Accra.
All right. Thank you very much, Dr. Michael Usu. Dr. Michael Usu is a virologist with the KCCR. He's also a lecturer at KNUST. Over to you.